Hey team, let's jump into our conversation on musculoskeletal conditions. So here in Patho, we're going to start with our first pillar concept for this diagnosis area, the idea of chronic inflammation and healing in different musculoskeletal injuries. This is a really incredible area to be thinking about because what you're going to see in clinic are patients who have conditions that just won't get better, and you're going to need to manage or potentially stop a state of chronic inflammation in order for the patient to get better. And it really matters that you understand what's going on to the patient's body on that cellular level. That way you can make good influences on their prognosis. Okay, because this is orthopedic, we have quite a few slides from some of our orthopedic faculty, which is awesome. All right, let's go ahead and jump in. So our pillar concept here is to understand the role of persistent pathologic chronic inflammation in a musculoskeletal condition, noting that an acute to chronic transition of inflammation is actually normal. So what we're talking about in this conversation is not normal chronic inflammation. This is pathologic. So keeping that in mind, because seriously, so many patients where it's a condition which has existed for many weeks, if not months, and you're going to have to manage a pathologic chronic inflammation state. So remembering our definitions as we jump in here. Chronic inflammation, the normal kind, is just where inflammation is taking longer to clear a pathogen out or to create resolution. In other words, tissue healing, right? Normal chronic inflam, the resolution should occur in a timely and coordinated fashion in which neutrophils, which are those early arrivals in acute inflammation, are swapped out from macrophages as the primary cell. So in that situation where it's chronic inflammation under normal, kind of more normal, managed and coordinated situation, macrophages are engaging in phagocytic activity as well as starting to mediate the start of resolution on a chemical level. Basically, they're calling in all their friends saying, hey, come do repair work, regenerate blood vessels, that sort of thing. In pathologic chronic inflammation, we have something else happening. Basically, cytokines are talking to other cells and telling them to come in, and they're doing this over and over to the point where they're kind of just sustaining themselves. It's almost like inflammation for inflammation's sake. This is an amplification loop. So you have cells that are active, including macrophages, and they don't need to be. These amplification loops create these pathologically present excessive and persistent immune and inflammation activity, and the result, ongoing tissue damage. So you have tissues that weren't infected, that weren't damaged, but because the immune system is there and active, it's creating damage. Yeah, a really frustrating situation. And so if this occurs for long enough, you end up with chronic inflammatory diseases. So in pathologic chronic inflammation, what we have is a failure to resolve inflammation, and that's what we're going into now. Okay, so again, looking at the same concept, but this time visually. So what we're looking at right now is here. So what we had is the initial stimulus, right? And what should happen is that there's a move over to here. You have healthy inflammation, the acute response, and then what should happen is that it moves through into resolution. But what we're talking about here is that it failed to resolve, and so we ended up coming over to here, this cycle of excessive inflammation and excessive immune response. So the failure to resolve the issue creates the amplification loop, and we go all the way through, and that's when we end up with a disease process. This is usually what has happened to many of our patients. It behooves us to recognize that this is all talking about cellular activity, but the patient is experiencing is basically something that hurts, some joint maybe that doesn't move properly, pain, dysfunction, inability to fulfill their life roles, and they are frustrated. This does not happen overnight. This takes a minute for it to occur, right? So what you might have is a patient who's been dealing with this situation, maybe even trying to get medication in there to stop this cycle, and it hasn't succeeded. So that's something to keep in mind, that all of this is going on the inside, and it has been going on for quite some time. Let's look at how chronic inflammation affects different orthopedic structures across different types of injuries. And as we're doing that, let's jump into terms again. Okay, a strain. A strain is an injury to a muscle. This is almost always from abrupt or excessive muscle contraction. In other words, it worked too hard. A sprain is a tearing injury to one or more ligaments of a joint. So this usually happens when it's asked to extend or forced to move beyond its normal plane of movement. It helps to remember that you strain a muscle, you sprain a ligament. Classic injuries, people strain their shoulder, like a throwing injury. Remember that the shoulder is held together basically with muscles. Or you sprain a ligament, like an ankle. What really hurts is one of the stabilizing structures of the ankle, which is typically a ligament. Subluxation and dislocation are a disruption of the joint's alignment. So some degree of contact between two bones has to occur in order for a joint to exist, right? There's an articular surface. And what can happen is you have a separation and then kind of a return, but not really. There's partial disruption of that alignment, and that's a subluxation. A dislocation is where there's a complete disruption of the joint and the articular surfaces of the bones that make up the joint are no longer in contact with each other. It's good to remember when we're talking about trauma-type injuries. A tendon is comprised of mainly collagen, in fact, over 3/4 of it. And a tendon aligns parallel to the line of movement created by the contractile tissue it's connected to, a muscle. Tendon itself is covered with a sheath for protection, and so that sheath is actually one of the structures that can get some pushing if the tendon becomes swollen or inflamed. Honestly, it's close to equivalent to bone in tensile strength, so this is pretty strong stuff. The way that a tendon is usually injured is excessive tensile loading or a laceration. In other words, something cuts it accidentally, or it's asked to do too much work in terms of like a stretching sort of thing. So tendon injuries, there's two types that we tend to interact with. One is tendinitis here. This is an inflammation of the structures that make up the tendon. Worse than that, sometimes a progression can be tendinosis. This is a degenerative process. This means that you've had an issue for a really long time in that structure. We've kind of moved past inflammation to this more degenerative process. This is characterized by lots of population of fibroblasts, remembering that fibroblasts are ones that bring in new collagen. Vascular hyperplasia, in other words, there's new vasculature that has developed trying to bring in things that heal, and unfortunately, disorganized collagen. Collagen needs to be aligned properly in order for it to work. When it doesn't, that's when things get stiff. Tendinopathy refers to a pain with a histopathology. In other words, you can see that something is wrong if you were looking under a microscope. So let's talk about tendinopathy a little bit more. This is usually an overexpression of certain types of collagen, disorganization of those collagen fibers, in other words, it's not all smoothly laid down, less collagen, and then just grossly altered fibroblast morphology. We'll talk about this a little bit more in terms of fibroblasts and their activity here, but in essence, what you have is ineffective structure. So we're coming all the way down to here, in which the tendon is no longer working properly in a tendinopathy situation. There's a lot of different things that are going on the inside here. And what can eventually happen is that you have tissue failure, right? And that's when things can tear, either partially or fully. So back here, that's what we were talking about earlier with the kind of inflammation process. When this occurs over and over, that's when we end up with that histology that we were talking about earlier with the chronic inflammation processes. And you can end up with this extreme of tendinopathy that can lead to tissue failure. So again, just to kind of give you a good example, you can have something called Achilles tendinitis, where there's inflammation and irritation to the Achilles tendon, usually real low, like down at the insertion point here. And this is a repetitive trauma. So for example, let's say somebody is running and they're wearing the wrong shoes, and they're running and running and running because they're trying to be a really amazing soccer player. And they keep getting swelling and inflammation and pain down there. Well, if you give it long enough, you can end up with Achilles tendinopathy. And what occurs over time is you actually have a lot of different pathologic processes going on due to repetitive microscopic tearing of the tendon. The tendon is not being used in a biomechanically efficient way, plus it's got a lot of immune activity. You basically have a chronic inflammation situation, and so you can end up with really, really serious injuries, including the buildup of spurs, or possibly injury to bone structures that tendons are attached to. So this kind of answers the question of how these structures end up in a non-healing situation. It's also why these conditions are notorious for being a bit challenging to treat, especially in athletes, because what is an athlete doing? Well, they're continuing the trauma that led them in this situation, right? So the repetitive trauma, unfortunately, can be continued use. Yeah, and so this is, of course, what you're going to spend your second year learning, is how to change the way that they're using and how to manage. But this gets to the sense of why they're even coming into your practice. They've had microscopic and repetitive injury. Here we are. Now we have enlargement and spurring, calcification in a tendon, all sorts of things happening because of a chronic inflammation state. Ligaments are incredible. They connect your bones, right? They're usually injured with excessive tensile loading. In other words, they're pulled apart. So they come in different levels of injury. One in which you're more mild, grade 1. Grade 2, now you have some actual tears and the joint becomes more lax. And grade 3, in which you're probably going to need some sort of surgical intervention because the ligament is completely torn. So immobilization helps with this, but it's an area in which we have to be really careful because while immobilization can promote healing, there's a lot of trade-offs that come in with immobilization of any structure of the body. So one thing to keep in mind is that there's kind of an earlier in the injury logic, and there's a pathophysiology which influences our decisions as healthcare providers, and then later when we're recovering, in which physiologic motions may be useful during repairs on that small cellular level so that your new collagen that's getting laid down is better at its job. Yay, PT helps with that. That's part of why we're so effective as providers in ligamentous injury. We help new collagen lay down well, and that means that the recovery is more perfect, right? Because remember that not all structures repair well, but we can improve the odds of it being a useful repair if we're in there, if PTs are in the mix. So let's talk about this a little bit. So collagen is part of ligaments as well. And collagen is everywhere, mind you. That's why I have this image right here. This image is just to show you that collagen is everywhere, right? That's the only point of this right here. But what we're looking at with ligamentous injury is that prolonged immobilization is an issue at the level of the muscle, right? So you're keeping, say, an elbow stable so that ligaments can heal, but you're going to end up with these trade-offs. And so that's one thing to keep in mind. We have animal models to show us exactly what goes on. And basically you're getting a swap out of nice mobile collagen fibers like type 1 to less mobile type 3, which means, sometimes that's all you've got, right? It means it's really, really important for PT to get in there and do this thing right here. Organize, assist in mobility resolution of the injury so that mobility is restored in the best way, and the way that we're actually influencing the body on a patho level is helping that newly formed collagen lay down in a useful way. Okay, so here's another image to give you a sense here. This is a rat that they had, and they immobilized the knee joint. So this here is the femur, this here is the tibia, this is the front of the knee here, this is the back of the knee. And what you're looking at right here is what we call the posterior capsule. These are the structures that are just at the back of the knee, and a lot of them are passive structures such as ligaments, and there's some tendon in there and all kinds of other things, right? But what we basically have here is over the course of 4 weeks, observe how this space right here gets thicker and thicker, okay? So that's what we're looking at. In fact, if you really take a good look, you can see that the posterior capsule is getting thicker and thicker in just 4 weeks, and that the femur actually kind of starts to shift a little bit. Like, look at the position of the femur here versus here. See how it's actually, by the time we get to 4 weeks, it's actually been bumped this way. It's kind of shifted anteriorly, and it started to glide into a little bit. Look at this angle right here. This is a nice straight line here. Whoops. And this is a little more bent, right? The knee's actually being forced into a little bit of a flexed position because of all of this right here. This is non-contractile tissue, right? So again, your take-home message here from this awesome science is that structures that need gravity and mobility will deteriorate and reorganize poorly in immobilization scenarios. That's the big thing you take away from this particular image here, okay? All right, let's jump to another structure, articular cartilage. Articular cartilage is a really cool structure. It has amazing tensile strength. You can squish it, you can pull it, you can do a lot of things to it. Mostly what you can do is squish it. It has a large compression force tolerance, and it still returns to its original shape and dimension. In other words, it looks the same when you give it a squish. So this is the sponginess that we talk about with articular cartilage. Now, when it's injured, this varies a lot based on the depth of injury. This is not the most vascular tissue, and so what you really need is nutrition via lubrication. It's a really complex thing that you'll get into more with Dr. Nichols. but it's something to keep in mind here. Now, we're taking a look at articular cartilage. It behooves us to kind of think about how thick we're going in, right? So here is the level of bone, okay, but there's levels of bone as well. So let's think about partial thickness versus full thickness injuries to cartilage. So a partial thickness only goes into the cartilage, okay? So that's this area right here. This is partial. Full thickness goes all the way down, actually, into subchondral bone. So this is full thickness. That's pretty serious, right? And that starts to give you a sense of the nature of healing in these two contexts. So a partial thickness articular cartilage injury can heal, but it's going to heal incompletely because these structures have a difficult time getting nutrition via blood flow. So you're not going to have that much proliferation and reestablishment of the normal matrix, but there is some. So there's healing potential, but it's limited in a partial thickness injury. In a full thickness injury, we're all the way into the bone. So what that means is that you have to have some healing via replacement. Remember, anytime we swap out an original structure for a substitute structure, it's not going to work as well. So that's what's happening in a full thickness cartilage injury. So what occurs in this type of injury, in this area here, where it's deeper in the subchondral bone injury, is that you have healing via bone stem cells, and these stem cells differentiate into chondrocytes and fill in the gap, okay? So they're going to fill in this area that got injured. The problem is that this tissue that comes in is not the same type of cartilage. It actually resembles something called fibrocartilage, and this cartilage is not nearly as strong in terms of tensile strength. In other words, it doesn't compress as well. It just doesn't behave as well as the original material. This is just the nature of healing in that part of the body. Someday maybe science can change it, but that's pretty serious, pretty serious recovery of something that was lost. So what we have here is effectively scarring. Honestly, it's a form of scarring. If you remember earlier when we were talking about fibrotic healing, this is the version of that, but for cartilage. So when you're talking about scars on the skin, this is the version of this in the cartilage. So this fibrocartilage replacement tissue is less resistant to stress, and actually it eventually deteriorates and accelerates arthritic changes. Why? Because we've gone deeper into the bone, right? So this is why this is such a challenge here. The stuff that comes in is less effective. It doesn't have the same functionality as the original tissue, so you have significantly suboptimal healing here. It also means that these are areas in which we try to influence what's going on. Basically, you want to try to encourage healing to occur in this cartilage area because you do have some chondrocytes playing a role, right? Chondrocytes are what make up cartilage. So you want them to lay down good stuff as much as possible. So with these partial thickness injuries, this is why they say there's a much better prognosis, because you can actually get more of the original stuff back a little better, but it's always kind of an area in which you're going to have continuous wear and tear. That's something to keep in mind. It is a permanent defect. It's not a recovery of the original structure. So remembering that in osteoarthritis, this is a degenerative condition of synovial joints causing cartilage destruction. This is something to keep in mind here. So there's a lot of different etiologies on how osteoarthritis occurs, and you'll explore that more fully in your other courses. But one thing we want to keep in mind is that there is an inflammatory type. In other words, some injury leads to significantly more injury because you have too much immune system activity in there. There's one etiology in which you have this constant low-grade chronic inflammatory activity, and this inflamed state, chondrocytes start changing their activity, and they're not as effective as they were before. So that, compounded with our old friend leukocyte-mediated tissue injury, results together, and you eventually have, between that and the wear and tear component, in other words, the physical component, you have, so this would be the trauma injury, so that's the wear and tear one. You basically end up with this significant degeneration of cartilage that leads to folks getting joint replacements because it becomes a bone-on-bone situation. So there's a lot of forces that lead to that bone-on-bone situation. It's not just one thing, but this gives you a sense on one of them, a chronic low-grade inflammatory state. So all of these things together combine to influence different tissue healing times. Now this has a purple hexagon because you don't need to know this for me. It's just to give you a sense of it. So what I really want you to take a look at here as we wrap up this part one here is look at the bad ones. Yeah, all these ones that take longer. Muscle, grade 3, can take upwards of 6 months. Tendon, in a tendinosis situation, 6 months. Ligamentous sprain, grade 3, 6 to 12. And meniscus labrum, remembering that these are cartilage structures, much longer. It's something to keep in mind. When you see these longer time frames, what's going on is a chronic inflammatory state, right? Extended time to heal, by default, that's going to give you chronic inflammation. So that's something to keep in mind. This is going to be a normal thing that you encounter in the recovery of your patients with orthopedic conditions in a chronic inflammatory state. All right, let's jump over to part 2.